right. Yeah, that was sweet. Yeah. Go ahead and get started. Today we have our third speaker for our spring Coughlin-Logan Center for Addiction Research and Treatment seminar series. If this is your first time with us, we feature 6 of these talks throughout the year. We will be announcing our fall series sometime in June or July once we finish up the speakers we're going to invite. Today, we're very fortunate to have Dr. Angela Haeny. She's an assistant professor of psychiatry at Yale School of Medicine, and she's the director, as you can see here, of the Resilience, Empowerment, and Addiction Leadership Lab at Yale. Dr. Haeny received her PhD in clinical psychology from just up the road at Mizzou, so we'll try not to hold that against her here at KU. And I first was introduced and came to know Angie when I was a postdoc at Mizzou in their alcohol training program. And it's been really great to see after you finished up there how you've launched your career. So it's really exciting. She did her clinical internship and her postdoc fellowship at Yale before staying there to join their faculty after she completed her postdoc. She'll tell you about her research, but just briefly, she's interested in how alcohol and drug treatments can be prioritized for populations with specific disparities, particularly Black adults. She addresses constructs such as craving, racial stress, identity, internalized oppression, and social determinants of health. She's been funded by a K Career Development Award at NIAAA and has been getting some really good news potentially on some R01 grants that she's going to tell you a little bit about today. So that's really exciting for her. And she's been recognized for her work, including a Distinguished Contribution to Diversity in Psychology Award and an Early Career Investigator Award. So please join me in welcoming Dr. Haeny.
Thank you for that lovely introduction. Yes, I did take the risk and check my grant score right before this, but feeling good. So, yay. All right, so I'm excited to be here with you all and to talk a little bit about my work and the ways in which I've been trying to move forward with achieving health equity and addiction. And I always like to start with a land acknowledgement. And so when I was looking up your institution, I came across the Kansas Association for Native American Education, which offers this toolkit for helping folks who are educators in Kansas and want to utilize land acknowledgement to go beyond just making a statement and to do like the next steps in the work, which I thought was really cool. And they also talk about, when we're thinking about land, acknowledging the ancestral land that we're on, that really we're acknowledging the people. So we can call this a people acknowledgement, which I thought was cool as well. So in case you weren't aware of that, this is just like a screenshot of the beginning of the PDF that this toolkit exists. And kudos to your institution for creating this. So I'm just gonna go ahead and read out this land acknowledgement. So Kansas is the ancestral home of 7 tribal nations, most notably the Kaw, Osage, Pawnee, and Wichita nations, who inhabited the lands for thousands of years before being forcibly removed. We acknowledge and honor the diverse indigenous communities who continue to live, work, and thrive where we are located. While Kansas is not part of their ancestral homelands, there are 4 federally recognized nations that have reservation land bases in Kansas today: the Prairie Band of the Potawatomi Nation, the Kickapoo Tribe of Kansas, the Iowa Tribe of Kansas and Nebraska, and the Sac and Fox Nation of Missouri and Kansas and Nebraska. These nations were forcibly removed to Kansas in the 19th century and remain here. Some of these nations have relatives that are also federally recognized in other parts of the U.S. As guests on these lands, we acknowledge the systemic policies of genocide, relocation, and assimilation that continue to impact Indigenous communities. And in an effort to honor and remember the violent histories and legacies of settler colonialism, we also want to acknowledge that we are in a young country and that has developed rapidly, and much of the economic progress has resulted from the unpaid labor and forced servitude of people of color, particularly enslaved African people. And we recognize that collectively acknowledging the historical labor that has allowed our society to progress to where we are today is key in reconciling and redressing our violent history and the legacy of settler colonialism. So to give you a quick overview, I'm going to talk primarily about my work focused on targeting racial stress and craving. And then I'm going to share a little bit about some of the work I've been doing with Collaborators evaluating the comparative effectiveness of psychosocial treatments for reducing cocaine use among Black adults. And I'll talk briefly about developing a patient-reported outcome measure of craving. And I'll end with, sharing some tips on how I've been navigating the current times in case that's relevant for folks here. So hopping right in, national epidemiological data from the National Survey on Drug Use and Health demonstrates that Black people drink less than white folks. And so in the darker green bar, that represents Black folks, the lighter green bar represents white folks. And this is true for lifetime alcohol use, and similar when we look at past month heavy alcohol use and past year alcohol use disorder. We see this similar trend where Black people are drinking less than white people. However, despite this, Black people who do drink tend to experience more alcohol-related problems. And so this includes telescoping effects, such that there's a shorter period of time between first drink and the time to developing a first symptom of alcohol use disorder. Among people who develop alcohol use disorder, they tend to experience more severe and more persistent alcohol use disorder symptoms. And people with alcohol use disorder experience, Black people with alcohol use disorder experience more social and health and legal related alcohol related problems, highlighting the need to understand the factors that contribute to drinking among this group. Also, national epidemiological data, this is actually from NESARC, so the National Epidemiological Survey on Alcohol-Related Conditions, shows the rate of those who have an alcohol use disorder who report needing treatment but not going. And so this is a cross-racial and ethnic group, and we can see that for Black folks, roughly just under 19% of Black adults report having an alcohol use disorder, needing treatment, but not going. Data from NISDA show that 11% of Black people meet criteria for past year alcohol use disorder. However, under 8% report participating in specialty alcohol use disorder treatment. And when it comes to treatment outcomes, the data are mixed when we're looking at reductions in substance use. So for Black folks who attend treatment, there are some studies showing comparable outcomes, and there are other studies showing that substance use reductions were poorer outcomes for Black folks. When it comes to treatment retention and satisfaction, we see lower retention and satisfaction among Black folks. And when we think about ways that we can improve treatment outcomes among Black folks, one way is by ensuring that our treatments are addressing all the needs that Black folks have. And so maybe a part of that is attending specifically to constructs that are especially relevant to Black people. So there's long-standing evidence demonstrating that stress is a major precipitant of alcohol and other substance use. And this is a diagram from one of Dr. Rajita Sinha's recent papers, just showing the association between stress and substance use. We know that increased stress can lead to increased substance use, and that chronic and binge alcohol and drug use can disrupt the stress reward system. And that acute withdrawal and absence-related distress can lead to more stress, thus leading to more drinking and substance use. And also we know that minoritized stress theories indicate that Black people experience stress due to racism. So racism is a system of beliefs, policies, and practices that work together to privilege those who are perceived as white in our country, and oppress those who are perceived as a person of color in this country. Now, racism operates on multiple levels. So when we're talking about racism, it's important to know what level we're talking about. And so Dr. Kamara Jones, she has this great paper kind of going into the levels of racism. But the institutional levels, essentially the differential access to goods, services, and opportunities, that essentially our opportunities and goods and services are not evenly distributed in our society, such that white folks have greater access to these things and folks of color have less access. And this includes things like quality healthcare, livable wages, quality education, access to safe neighborhoods. So that's at the institutional level. Then the personally mediated level, or at the individual level, this includes things like prejudice and discrimination that can happen both overtly or covertly, which is often referred to as racial microaggressions. And then intrapersonally, racism can operate at the interpersonal level. So this is internalizing or believing essentially in stereotypes about your racial and ethnic group, and maybe even perpetuating them. So I also want to acknowledge just the cumulative nature of racial stress and trauma. And so racial stress can be defined as experiences of racism that tax resources and or threaten the individual. It's important to acknowledge, similar to other complex traumas, the cumulative nature of these. And so it's not just, an explicit event that might happen, like a quote unquote criterion A event. When we think for folks of color who have historical and cultural trauma, like I discussed earlier in the people acknowledgement, whether it's colonization or slavery, or forced into boarding schools, that contributes to stress response. And then there's daily hassles, such as overt or covert racism or microaggressions that people might be experiencing. So then if someone does experience a quote unquote criterion A traumatizing event, it's that coupled with these other things that come along with that. So it's an accumulation. And especially if we're talking about a racial stressor, often there's experiences of invalidation, like, oh, they didn't mean it that way, or you're just being sensitive, or that didn't really happen. And that further compounds the stress of that situation, not to mention institutional barriers or barriers to treatment and institutional racism. And so Clark's biopsychosocial model of the impact of racism on health builds on Lazarus's model of stress and coping, and suggests that racism profoundly impacts biological, physical, and social well-being, contributing to racial health inequities. So racism can contribute to a heightened stress response, which can deplete resources for coping and can increase engagement in maladaptive coping behaviors such as drinking and substance use. And data from the Stress in America survey indicate that Black people are more likely to report racial discrimination as a major stressor relative to other groups. Excuse me. And this meta-analysis shows the association between racial discrimination and various alcohol outcomes among Black adults. And you can see that for almost all alcohol outcomes, they're within the range of significance. For alcohol use disorder, the effect size doesn't reach the level of statistical significance, but you can see it's larger than some of these others, but there's fewer studies contributing to that effect size. And so it's probably a power issue. So essentially, racial discrimination is associated with various negative alcohol-related outcomes among Black Americans, highlighting the importance of considering this as a factor when we think about treatment and ways that we might improve our treatment for Black adults. Now, when we think about mechanisms, there's extensive research documenting that craving is a key mechanism that links stress to alcohol and other drug use. Craving is now a criterion in the Diagnostic and Statistical Manual, and it's a major target in many behavioral and pharmacological treatments, making it an important factor. However, a few studies examine the link between racial stress and substance use among Black adults. And so now there's becoming more studies available that are looking at the impact of stress on craving. But I want to highlight Dr. Sarah Peterson's work, she was the first to examine this in an observational study using ecological momentary assessment over a 10-day period of Black and white young adults who drink alcohol. And she found among Black participants in her study, higher average stress was associated with higher craving. Within-person associations between momentary stress and craving was higher. Momentary increases in stress were associated with higher momentary craving, and momentary increases in stress predicted subsequent increases in craving. However, this study did not look at racial stressors specifically. So other paradigms that seek to understand the impact of stress on craving includes work from Dr. Rajita Sinha's lab using her personalized imagery script procedures. And so just to give you a little bit of context of these procedures, they're standardized procedures where folks come into the lab and they report on these 3 different situations, which I'll detail in a second. But essentially, it's a standardized way to understand the impact of stress and alcohol cues on, or compared to a neutral or relaxing situation on constructs like craving and emotional response. And so folks come into the lab. That's usually done over at least 2 sessions, maybe more. But the first session, participants will report on 3 different situations. So first is the most stressful experience they had in the past year that did not involve drinking or drug use. The second, depending if it's a alcohol or drug study, it's a recent situation that involved alcohol or drug use, but was not stressful. And then finally, they'll report on a relaxing or a neutral event that did not cause physiological arousal and wasn't associated with any substance use. So folks are brought into the lab. The first session, they're reporting on these 3 situations, and the research assistant will ask all the information that's needed to create a very specific structured script. The research assistant will use that information to then record an image that the participant will listen to during the experimental protocol using headphones. And in the second session is when the experimental protocol happens. So the beginning of the second session, there's progressive muscle relaxation training to help folks use those skills to get back to baseline between images. And then also imagery training to help people to fully visualize the image as if it's happening again. And then they participate in the experimental protocol. So at baseline, they'll give their ratings of craving or emotional response, physiological indices, whatever is being measured. And then they'll listen to one of the images, the order is randomized. The recording is about 4.5 minutes, followed by 30 seconds of quiet, just to continue kind of listening and imagining the situation. Then they'll provide their ratings again, craving, emotional response, physiological indices. And then they'll do progressive muscle relaxation to bring them back to baseline. And then they could be exposed to another image, or that could be done in another session, depending on the protocol. But using these procedures to examine stressors reported by Black folks could be one way of thinking about or learning about ways that we might consider adapting treatment, which is the basis of my career development award. So the first project I did for my K was Brigida's been doing this for a long time, so she has a lot of data, and she actually did a thematic analysis of her data, specifically of the stress scripts, and found the majority of the scripts reported were relational or interpersonal in nature. And I was wondering, well, if we were to attend to or have in mind the reality that Black folks experience unique stressors such as racial stress and do a thematic analysis, would we find that or not? And so the first project that I did using her data was to do a subset of, I pulled a subset of scripts from 36 Black participants and did a thematic analysis. And as hypothesized, racial stress themes did emerge. And so just to give you an example quote, "You see a substitute teacher that the school doesn't use too often. She's looking at you strangely as if she's trying to figure out who you are. Now she's staring at you. You try to ignore her, but you can feel her eyes all over you. You wonder what she wants. All of a sudden she says with a little laugh, 'Oh no, you're not that one. Your hair is different. I can't tell one from the other. You can't believe what just came out of this woman's mouth. She may have said that all Black people look alike.'" So other secondary analyses I did on Regina's project was to look at whether or not there are differences in the stress and cue response relative to the neutral condition between Black and white participants. And essentially, we did not find differences in stress and cue-induced craving effects between Black and white participants. I also examined whether or not there were differences within the Black subsample between those with and without alcohol or substance use disorder. So these are folks with alcohol or cocaine use disorder is how we're operationalizing substance use disorder in the sample. And, similar to what we hypothesized, those with the substance use disorder had a greater craving response in the imagery to the stress condition and the drug cue conditions relative to the neutral conditions. So then the next step was to adapt the procedures to elicit racial stressors specifically. So in doing this, we worked with community scholars. These were folks who identified as Black, some with lived experience with alcohol use disorder, who were served as pastors, elders, community leaders, or organizers in the New Haven, Connecticut area. We met over Zoom for an hour-long meeting where I described the goal of the project, shared with them the current procedures, and just got feedback on how we might adapt those procedures and things to consider as we do this work. And we used that to finalize the adapted procedures. The community scholars were compensated $50 for their time. And so we adapted the procedures. And so then I wanted to pilot the procedures to see, do they indeed elicit a stress response? And so I did this over a 2-session period, and for the experimental conditions were racial stress and neutral for this study. So I recruited 20 Black participants with past or alcohol use disorder, 45% were female with a mean age of 37, and used linear mixed effects models to see if there was a change in craving and emotional response from before to after the imagery. And we hypothesized that the racial stress image would lead to greater craving and emotional response relative to the neutral condition, which we found. So you can see here that there was greater craving from before to after the imagery in the racial stress condition, which is the black solid bar, compared to the neutral condition, which is the striped bar. We also saw greater stress or anxiety response in the racial stress condition relative to the neutral condition. And we saw greater emotional response in the direction we'd expect. So we saw greater anger, fear, sadness, anxious arousal, and decreases in joy and relaxation in the racial stress condition relative to the neutral condition. So to summarize, we successfully adapted the racial stress procedures to elicit racial stressors. We did find that racial stress led to increases in craving and emotional response relative to the neutral image. And so I submitted in R01 to look at the full paradigm in a larger sample. And that was the score I just reviewed. This is a 4th submission. It's a good score, but it's on the cusp, so who knows what will happen. The key thing is, in the context of thinking of health equity work, I had a lot of discussion with my mentors about what I do about this submission. Do I expand it? Do I look at other groups? Do I look at other stressors? Do I talk about general stress? How do I talk about this? Especially given the last round of reviews, were pretty positive, and it was a strength that I focused on Black adults. It was a strength that I was looking at I was targeting racial stress. And many of the critiques were mainly methodological and addressable. So I was like, this is what I want to do. I'm going to submit it, focusing on the group that I originally was planning to look at, looking at the constructs I was originally planning to, getting creative with the language, using acronyms, I don't know, just trying to get creative and trying to get it through the review process, and hopefully fundable process. But the reality is that I have other colleagues who have gotten excellent scores on their R01s and were not funded because they were focused on a minoritized group. It also seems to be institution specific. So I've heard some things about the institution I'm submitting to, that director is being more conservative, even though health disparities work is still fundable and other institutes are doing it. So it's a toss up, we'll see. But I am making an effort to continue to do the work that I've originally set out to do. And this is just one example of how I'm doing that. So also related to my K, I interviewed Black adults with alcohol use disorder who have a treatment history to hear from them, their experiences with craving, their experiences with racial stress, craving, and their thoughts on how treatment might be improved to better meet their needs. And these data were analyzed using a narrative phenomenological approach. And this paper is in I'm still writing it up. But excited to share with you these preliminary findings. So a number of cool themes came up. One was many folks talked about the impact of stress from racism and how it triggered their drinking. So to give you some examples, I've used substances to deal with the stress of racism, especially going to prep schools and privileged universities with a lot of privileged people. Being around people who can't really talk to or can't really understand those would be things that would cause stress and tension in me and would drive me to drink. And that's on a daily basis. Racism doesn't have to be verbal. It can be a look, a body language, just emotion. So I deal with it on a daily basis, and that bothers me. And that right there will lead me straight to a drink, because I figure when I drink, I could block it out. Go get me a drink. It's an immediate response when you go through that kind of stress. Just get to the store, start drinking, get in your feelings, and it gets worse. It doesn't get better, it gets worse, because then you start to get angry. Then you might be in jail. It's not a good recipe. Either you're gonna be in jail or you're gonna be sitting there crying. Just mostly from my job, like a Black person working in job redacted and trying to work your way up, especially my dark skin, because I'm an African-American Black woman. And I guess coming home and taking a drink and smoking marijuana would calm me, and it'll keep me going for the next day. One participant shared an example of a stereotype threat. So this is fear of confirming stereotypes about your group. The example is, people would think because I'm African American that I'm always angry, and that makes me angry. And the agitation makes me want to drink. It does. The drinking calms me, believe it or not. And the anxiety of people thinking you're mad will make you mad. And then also a participant shared an example of internalized racism. So I've had inner racism. Sometimes you're not Black enough. They're calling me light skin. It's an immediate response when you go through that kind of stress level. Start drinking, get your feelings, and it gets worse. So structural racism also came up in the context of the accessibility of alcohol and the overrepresentation of liquor stores in neighborhoods. So for example, I'm trying to be an ideal, something that somebody can look at and say, well, not all African American males are bad fathers or criminals. I just don't want to be at the bottom of the totem pole anymore. Not only my ethnicity, it's actually the living situation. It's like, hey, y'all Black, stick y'all around a bunch of Black people and make sure the liquor store down the street and around the corner. So that's our major focus. That's all we see. We don't see anything else. It's like the world just created that for us to notice. Before you get to Walmart, you're going to see a liquor store. So I was going to Walmart to buy a soda. I look, oh, I can go into the liquor store and buy a soda. What happens? Now I'm drinking. It was also shared that components of racial identity, like having a greater sense of racial pride, was discussed as protective against the effects of racism. Maybe I should pause for a second. So when we think about racial identity development models, essentially it's all of our understanding of the effects of our race and how it impacts our experiences. And so there's research showing and there's multiple racial identity development models across racial and ethnic groups. So there's different ones for white folks, Black folks, Latino folks, but there's even more specific like Filipino. And so research shows that for those who are, depending on where you are in your racial identity development, it can impact how it can either be protective or it can increase risk for substance use. So for those who are early on in their racial identity development, maybe they're not as aware of the impact of racism in their lives. So thinking for Black folks specifically, they experience racism. Because they're not as aware of the impact of racism, they might internalize those experiences instead of properly externalizing it to what it is and labeling it as racism. And that can increase risk for drinking. So it's theoretically how we think about it. And then those who go on, who are further along in their journey and they're aware of the impact of racism in their lives, they experience it, they know to label it as racism, they know to properly externalize it for what it is, as opposed to internalizing it as something wrong with them. And that then is served to protect them. It causes less stress for them because they can label it for what it is, and then therefore are less likely to drink is the theory. So here is an example where somebody shared about the impact of racial identity. So the quote is, I try to calm myself down, and usually it comes from within myself because I know who I am. I know where I'm from. I know that I have a background and a history to be proud of. So I guess when it does get to me, it's not for too long. But yeah, it can be annoying for a bit, but usually I can pick myself up. So it usually comes from within. When I was younger, it got to me more. There were people around me who were supportive enough that I didn't go drinking. As I got older, it's like water off my back. I think the more you come into your own, the less how others perceive you starts to affect you. So participants also reported different ways or different treatments that they use. So many reported using typical specialty treatments, inpatient, outpatient, rehabilitation. Some people reported talking about their drinking and general mental health treatment. Some people talked about using spiritual approaches or culturally traditional healing approaches. And then folks also talked about different strategies they use for coping with racism. So one person shared, I've heard things like racist remarks and kind of just made me upset, but I learned you have to not let it give you a stroke or a heart attack. You just have to meditate and find a way to find peace instead and not let it destroy you. Another example is I got to find different outlets because the racism is going nowhere. Me being Black is going nowhere. So this can't keep flying. You know what I mean? So I'm trying to get back into school for nursing. So this has got to go. Something else has to be done. Participants also shared about unhelpful experiences they had in treatment. One involved difficulty connecting with their clinician. So it's more geared to white people because they don't understand racism. They don't understand the stigma that you get when you walk into a room just because you're Black. They don't understand that. They can't identify with that. They think they can, but they can't. They don't get the clutching of the purse just because you walk by. No, they don't get the hesitation of other cultures when you're around, of how to act, how to speak, how to do anything. They don't get that. Another example is they let us feel like you can be honest and open. You don't want to say the wrong thing while somebody's in there. So they didn't want nobody to feel like they're being targeted. So some things we could talk about, and some things they would just clip us right up, like, we're not going to discuss that here today. And I'm like, here we go again, like my feelings don't matter. So essentially experiences of racism were not, it clearly wasn't welcome to discuss that, be discussed in a multiracial group. And then participants offered their recommendations about how treatment could be improved. So one was increased cultural humility training for clinicians. So the sensitivity training, the history, the struggle. But as in the training, I don't know how to put this, it needs to start with the counselors. The substance itself, I think, is across the board helpful, but they just need to train the counselors how to be more receptive to Black people. And then others shared that they would like explicit discussions of racism and treatment. So an example quote is, it would be better because then I would feel like they're knowledgeable and they're qualified. I would be greatly satisfied because then I feel like they would be better than just acting like nothing's wrong. And there's no need for civil rights movements. You can talk about it more so people can have a better life and not fall off from work or school or anything because of racism and drinking too much because of it. And then finally, but I think I think for the people of color, they're understanding how we react to daily microaggressions and macroaggressions from society. There should be a special session to help you not carry a chip on your shoulder because we're going to be living with these things for the rest of our lives. And there are people there who couldn't possibly imagine what we go through, what we face, what we hear, what we experience and feel. It could really touch the root of why a person abuses. I think a group led by an experienced Black person or a person of color who has a vocabulary to give us. It could be like a co-ed group to give us the tools to talk and think about these things. It could really touch the root of why a person abuses. Adding groups for people to discuss race and sex just makes the therapy more robust. They could help me put into words what it's been bothering me all these years because they've had something similar in their backgrounds. So that's usually how I know that they understand where I'm coming from. So to summarize, the primary objective of this qualitative study was to learn from Black adults what contributes to their drinking and how treatment could be improved. Participants reported on that stress from interpersonal and internalized racism contributed to their drinking, that structural racism increased the accessibility of alcohol, that an increase in racial pride made experiences of racism less stressful, and treatment recommendations include cultural humility training for clinicians, explicit discussions of racism and how to cope in treatment. Yeah, so for my final project for my Career Development Award, I will be working on developing intervention based on all of this work that's been done so far. So that will be forthcoming. But I want to change topics a little bit and just talk about other projects that I've been involved in terms of pushing forward health equity addiction research. And so I've had the great privilege to work with this amazing team of researchers through the NIDA Clinical Trials Network. We received funding for a concept through the CTN to use data harmonization techniques to pool existing clinical trials to evaluate the comparative effectiveness of psychosocial treatments for reducing cocaine use among Black adults. We're in the process of wrapping up that work, and we recently submitted another concept building on this work. And so we brought in to examine all stimulants, and we also expanded the population. So we're looking at all participants. We're not limiting to a racial and ethnic group. And this is an example of us being strategic and still being able to do this work because even if it is funded, we can still do subgroup analyses and look at Black participants. But the reality is that overdose deaths due to stimulant use is on the rise across racial and ethnic groups. And so there is a need. That proposal was reviewed favorably. We'll see what happens. But this is an example of, I don't love pivoting. People talk about pivoting your work, but expanding. I really like the term expanding. So this is an example of expanding the work that we've been doing, but still being intentional about thinking about how we can push forward work that advances health equity and addiction. And then another example is I've been working with this lovely team, Drs. Megan Morian and Stephanie O'Malley, on developing a patient-rated outcome measure of alcohol craving, so the Yale Alcohol Cravings Scale. The idea being that this would be the first patient-rated outcome measure of craving that could be approved by the FDA and then used for drug labeling. So although there are a number of craving measures out there, none of them have gone through the steps required by the FDA to be approved as a patient-rated outcome measure, which means that although we know there are existing medications that reduce craving, those medications can't be labeled as such without a patient-rated outcome measure of craving. So once that's established, then medications can be labeled specifically for reducing craving. And so we've been actually working on this since 2020. It's been a labor of love. I had some pilot funds to do the initial work to develop an item bank. So we gathered all existing craving items, over 1,000, and then we reviewed and standardized the items. A lot of them were redundant. A lot of them were very problematic, were double-barreled, used jargon. We're not assessing craving specifically, we're getting at other constructs. And then we obtained patient feedback. So this is in the form of focus groups. And this is really important because you want to make sure that you're tapping at all aspects of the construct. And you want to make sure that you're using language that represents the language patients use to describe their experience of craving. And then we also conducted cognitive interviews, and we're actually going to do a second round because we made further revisions to the items, but we want to make sure that patients are interpreting the items the way that we expect them to. We want to make sure the instructions are clear, that the time frame is clear, and make sure that there's nothing that the patients feel like it's missing from the list of items that we have narrowed it down to. We're at 46 now. But this, you can see in this project, this is a measure development project. It's not explicitly health equity, but given my area and what I'm interested in, I've been intentional about making sure that when we're getting patient feedback, that it's from people with diverse backgrounds, so that we're ensuring that the measure that we're developing represents experiences of craving, regardless of racial identity and other backgrounds. And so the RO1 that just scored very well, involves evaluating the psychometric properties of these items, doing the first initial cross-sectional work. And as part of that, we will be evaluating measurement and variance across several subgroups, including racial and ethnic group. And so in this example, this is where, thinking about the work that you might be doing and how you can still be intentional about making sure that it's applicable across various demographic groups. And so, with many of us, we might have different lines of work, different lines of research. And the reality is, depending on what funding priorities are available, that can inform what direction we kind of go with our work. And so I kind of think of this similarly, although it is very different. I want to acknowledge that it's extremely problematic, what we're facing and the limitations that have been put on us and the structural issues that have been placed to prevent us from doing important health equity work. But I hope that we can persist through this and make it to the other side where we can explicitly talk about these things again, like we should be able to. And so for those of you who may also do health equity work, I just wanted to share a little bit about how I've been navigating the current climate and continuing in this work. And one is staying the course as much as I can. Like the work that I shared initially, focusing on racial stress, is very important to me. And I'm really excited about this work. And I want to be able to continue doing that work for as much as I can. So I'm going to keep trying to get funding for it and do it. Also thinking about expanding my work, which I shared. Sharing resources with others on how others are continuing to do this work successfully. Staying in community with folks who are doing this work. Being aware of stereotype threats. So I've heard firsthand people who are tempted to just, want to leave academia or leave the field because of not being able to do the work that's very important to them. And that is real. Like I hear that, I get that. And for folks with minoritized identities, especially how explicitly we're being targeted right now, there could be feelings of stereotype threat or fear of engaging in behaviors that might be consistent with stereotypes about your group, and then using that as proof, like, oh, I don't belong. Imposter syndrome might be exacerbated. And so being aware if that is happening for you, labeling it for what it is, and challenging that, reminding yourself of your successes, all that you've achieved, all that you've accomplished, and that you belong in this space here. And we need you here now more than ever because of what's happening now. We're going to see limitations in the pipeline and getting more folks with minoritized identity into this work, which means that folks who are already there, we need to stay as much as possible so that when we get on the other side of this, speak it into existence, we're going to get on the other side of this, we can reopen those pipelines again and intentionally engage in this work. And then finally, I've been a part of this lovely resilience collective that was started by my prior postdoc mentor, Dr. Carolyn Sartor at Rutgers. And this has been really cool. It's been with Denise Haeny, Adriana Espinoza, Alex Bauer, Christy Jackson. And we've been meeting monthly, sharing resources, talking about how we continue this work. And actually, we've been planning a conference. It's going to be at Rutgers. I don't know if you all have heard about and I know it's a little far, but it's open to everybody. But essentially, we wanted to create a space for people who are doing health equity work in addiction to come together, to be in a space with like-minded folks who care about these issues and talk about how we're pushing forward our work and to receive support and share resources and offer advice on how they can continue doing the work that they're doing. And Dr. Sarah Peterson is going to be our keynote speaker. She's an excellent speaker if you've ever heard her present. And so it's going to be a lovely time, an important space, and you all are welcome to join if you're interested. So I want to thank my mentors, collaborators, community partners, research assistants, and the funding to support this work. Shout out to trainees in my lab who've helped with disseminating this work. And thank you all for your time and attention, and open up for any questions you might have.
I'll start with one.
Yeah.
So you talked a little bit at the end about the pipeline
Mhm.
and this idea that some of your participants were saying that it would be more beneficial or more welcoming if I had a person of color as the person leading the group or as my therapist or whatever. But with this, we've known about the leaky pipeline for a while, and now it's almost like there are legitimate barriers being put in place. Do you see that there's sort of a light at the end of the tunnel for that? Because it seems like, yes, that they're identifying that as a key need, but if there aren't the trained professionals there, then how do you really go about addressing this?
Well, first, this is a great question. I appreciate it. First, I will say that anyone can and should engage in this work, and that it's up to us in the field to do better at training clinicians to be able to have these discussions. And that it's important that even though it seems like there's been a movement towards shared understanding of the acknowledgement of minoritized stressors and how that could be impacting substance use, we haven't been intentional about thinking about what does it actually look like to discuss this in treatment? Are we using explicit measures to assess this so that we know whether or not this is relevant to their presenting concerns or their reasons for seeking treatment? And so thinking about what language we can be offering clinicians to be explicit in creating a space when they're meeting with folks so they know that this is a place where these things can be talked about if it's relevant for them, which involves doing training. So making sure that we're providing training for clinicians to feel comfortable engaging in this work and training them to be able to talk about this in treatment and like, what does that look like? And that's what I hope to do with like the treatment that either adapting or developing and offering clinicians language and approaches for being intentional about targeting this within substance use treatment. So there's that piece. So I don't want to say like, yes, there are some patients who maybe have a preference for people with their shared racial and ethnic identity, but that is not enough. And just because somebody has a shared racial and ethnic identity, it really depends on where they're at in their racial and ethnic identity development, what their training is, because clinicians of color, we are all subject to the same biases and issues as anybody else. And so that's not enough. Like the training has to be there for everybody, period. And we do need to include, we do need to address the pipeline issues to make sure that we are making sure there's representation of clinicians that represent our patients that we're seeing. I don't know what, given the current times and the barriers are being put in place in terms of, and even applying for graduate school, like clinical psychology programs, it's like a completely different world. It's, you have to have years of post-bac experience, which means like making no money for years of time, and then going into grad school for years of time, still making no money. And so that means like a very privileged group of people are going to be able to do that before they get in. It's like you have to apply 4 years and have multiple publications before you. And so already that has been an issue even before our current political times that we need to figure out. And that's absolutely going to impact the pipeline. So I think that we need to be intentional about putting our heads together and thinking about these issues and what we can do regardless of political climate to be, and also getting creative. You know, if you really value this work, how can you get creative in making sure the representation and who you're recruiting, and given the limitations, the structural limitations in place right now.
Could you talk a little bit about, so the focus groups that you did with community members? Could you talk about like, how did you go about like, engaging with them? Were there specific, I know you mentioned some might have had like prior alcohol use experience or current, but like, what did that look like and how were you thinking about like the group that you wanted to kind of inform your work in that way?
Yeah. So let me back up for a second. So right now, the grant that looks like we'll get funded is focused on developing the Yale Alcohol Craving Scale. But when we set out to do this work, we actually were aiming to develop, and still are aiming to develop, a multi-substance craving measure. But when we were writing the grant, the work that would be involved, and we were doing across the 5 major substances, so cannabis, stimulants, opioids, alcohol, nicotine. But the sample size that would be required to do the psychometric, it just wasn't a feasible grant. So we had to narrow, like do substance specific. And then the idea, it would be that once we do all this work in opioid craving, that there is a group that's already doing that work to develop a patient-rated outcome measure of opioid craving specifically. But then once we have all the data, we can pool it and then look at multi-substances to see if we can find core features of craving that cut across these major substances. So with that in mind, when we were recruiting the focus groups, we did the focus groups for across these 5, so people who use one of these 5 substances. So we have focus group data for each group, and cognitive interviewing data for each group. And so we made sure that they endorsed craving for one of the 5 substances. And we created focus groups based on craving for the same substance, and that we made sure there was a mix of people who had a treatment history, a mix of people from various racial and ethnic groups, and age and education status. It wasn't like I didn't necessarily ensure that we had a certain number in each, like strategically, but essentially I just kind of kept an eye on who we were recruiting. And thinking about how we can be intentional about recruiting from other places if there were certain groups that seemed to be missing. And the idea being that when we do the measurement and variance testing, hopefully we will find a variance because we will have gotten feedback from patients from various backgrounds. So this construct, we are hopefully tapping into a construct that is representative across these various subgroups. But we'll see.
And could I also ask, could you also talk about your experiences with the community group of scholars that you asked to give you feedback on the racial stress paradigm that you were developing as well?
Mm-hmm. Yeah, so that was how I connected with those scholars was through my mentor, Dr. Sherelle Bellamy, who does incredible work in the community. Like she's so well connected. She's been like training me as part of my career development award. That's been like one of my training aims is qualitative work and community participatory work. And so she's the one who helped connect me with them and help me with leading those meetings, which has been cool. And she connected me with the folks with lived experience who I write in all my grants now and pay to offer the self-one healing circles, which I haven't talked about here. But so yeah, she kind of helped me there, which has been a fun experience. And then also Yale has this ambassador program. So Yale's trying to be intentional about involving the community. And so they recruited ambassadors who they pay and train in research. And they meet monthly, and researchers can schedule meetings with them to get feedback on our research materials, to partner with them in supporting recruitment efforts, and essentially to be involved in any part of the research aspect. So Yale also has this structure, and I've taken advantage of that as well. And I think some of the people might serve as both, like who served as our community scholars might have also served as part of that program too, but I didn't recruit them specifically through that program.
It sounds a little similar to something that the KU Cancer Center has, which is a patient and provider resource where people are part of this, and I think it's called, I don't know what it's called, it might be called Patient Portal,
Okay.
something like that, but if you want to do focus groups or things like that on anything related to cancer and the experience of cancer patients or cancer survivorship, you can apply to interface with this group, and you can hold focus groups and things like that, so. It sounds kind of similar. It's not quite community people, but it's people with lived experience.
Yeah.
Relevant lived experience.
Yeah, and so depending on what your needs are, like the Yale Ambassador Program is intentional about, I believe it's majority like folks of color within the New Haven community. And then my work, since I'm focusing on addiction, I want to, in addition to folks of color, I want people with lived experience with substance use disorders. So being intentional about finding both when I'm partnering with folks.
Could you talk a little bit about the work you're doing with the craving assessment? And specifically, I think like I have a kind of a vague sense of what craving is, right? But the assessment is essentially going to be a subjective assessment of people's experiences. So at least based on the work, what are the kind of the core features of craving that you and your expertise group have kind of identified to the extent possible with the work? So like what makes something craving versus an adjacent construct that maybe not exactly craving?
So an issue with many of our craving measures is that they are not just assessing craving. When we were looking at the pool of items, we cut out several items that tend to be looking at consequences of craving, or antecedents of craving, or we're too similar to withdrawal, or like other constructs, or getting at alcohol problems, but not the core features of craving. And even when reviewing the literature and the number of craving theories, the theories even overlap with other constructs. And so there's not even a single, a theory that you can point to drive this. I mean, craving, there's so many measures, so many items, but there's a lot, it's very messy. And so in our work, when we're narrowing that, if we want to get at the core features of craving, that do not overlap, we want to, of course, there's many constructs that are highly correlated with craving. But tapping in those where we can say this is craving and not anything else, what we hypothesized, we'll see if the data pull out, but we hypothesized that there's actually two factors, desire and preoccupation. And so our items, we're intentional about them being at a 6th grade reading level, which means they are super short. I mean, these are super easy, quick items to read. We're using very easy language. It looks very different from existing craving measures in terms of like all that's required that the FDA requires for developing the measure. But we have a lot of redundant items because we hope that they'll fall out in the psychometric testing. We'll test which ones seem to load. Obviously, we don't want a 46-item measure. So if it does turn out to be a 2-item or a 2-factor construct, then we want the shortest, so maybe a 6-item craving measure. But the items for desire, and also we're intentional about a severity within factor. So we have items that get it like, I crave alcohol, I want to drink, I desire, I urge. So that would be like mild maybe. And then let's see if I can think of an example of moderate. I have strong urges for a drink or something like that. And then severe might be something about, their desire for alcohols interfering in important areas or something like that. And then same thing with preoccupation. I think about having a drink. I imagine having a drink. I can't stop thinking about having a drink, or thinking about drinking interferes in some important way, like is overwhelming, or something like, so we're trying to also tap into potential severity within these sub-factors of craving. But we'll see how the data play out.
You kind of address this, but so do you, given that, do you expect that you might need different ones for different drugs?
Maybe that's what we'll evaluate. So our goal ultimately is to see if are there core features of craving that can cut across these 5 substances, or are they unique enough? We were talking a little bit last night at dinner that like even the language people use to describe craving might vary depending on the substance use. What language, which terms might be acceptable might vary depending on what their substance is. And so then that kind of makes a case for there being a substance specific craving measure. But I think that's what we hope, that's our goal, is to see if we can identify core features of craving that cut across, but we'll see. I don't know.
One final
Yeah.
point is that, do you expect it to be separable from like affective state? Some of this kind of intensity thing, if it's not differentiated or can be differentiated from affective state, so in other words, like break any sort of association, would that imply that basically these are affective state, and then the kind of the intensity of a craving experience it can still be craving, but they're fundamentally kind of tied, or can it be kind of disentangled? I'm just talking about like, if I think about my personal experience, right? So if I'm like, some of the kind of stronger intensity measures that you mentioned, right? For me, almost always correlate with affective state,
Right.
right? So I was like, oh, I'd like to have a drink, right? That if I'm just in like a regular okay mood or whatever, right? That I might endorse that, but the intensity of that my experience is not particularly hot, right? But it tends to be much more intense when I'm stressed out, or kind of in a negative active.
Well, and I can imagine that could vary for people with a substance use disorder versus people who drink socially. So I don't know, like you could imagine people who have, especially depending on the severity of their substance use disorder. So those that are very severe, maybe. Well, and then there's a lot of affect dysregulation because of chronic use. I mean, it is hard to tease apart.
Yeah.
I don't know, it's an interesting question. I'd have to think more about it.
One quick question and we can wrap up is, I noted that one of your participants in the sort of the middle qualitative study where you had all the quotes said that, I drink or I smoke marijuana, and then they went on. And so a lot of what you presented early on was about links between stress and drinking behavior. And that might be tied to some of the acute effects of alcohol intoxication, sort of the numbing, and maybe you go to sleep and it just sort of can cope better. Do you think the same sort of pathways exist for a drug like cannabis? Or do you think it might operate differently?
I think that should be tested.
Okay.
I think that'd be really interesting to test, but I don't know, off the top of my head, just thinking, why might it vary? I mean, I have been so far into the alcohol literature, so that's like mainly on my mind, but I know with Regita's data, like a lot of her participants include those who use cocaine. And with the similar finding in terms of stress has a similar impact on craving and cocaine use. But I don't know if she has as much with cannabis, and why would we expect there to be a difference for cannabis versus alcohol or cocaine?
Well, one of the things I was thinking about is like just differences in risk perceptions around cannabis's effects. It doesn't affect me as much. I'm not going to get addicted to cannabis in the way that I might for consuming alcohol. Like people hold these different sort of relative versus absolute risk perceptions about these different substances. And then also there might be sort of cultural factors that might make cannabis use more socially acceptable versus heavy alcohol use is not. So I just wonder how all of those things might play in here as well, particularly when we start talking about specific racial or ethnic groups, where some of those factors might operate differently.
Yeah.
So I think it would be obviously worth testing.
Yes.
But I don't know if it's going to be as straight of a path.
Yeah, no, that would be, I would be very interested in studying that, looking at the further.
Okay, so we'll wrap up here. There is an opportunity for trainees and staff, undergrads, grad students, anybody. If you'd like to come upstairs to the Copper Logan Center, if you didn't RSVP for lunch, you won't have a box lunch, but that's okay. You're still welcome to come for about the next hour and have some time to talk with Dr. Haeny about career issues, graduate school, starting a new career in this field. But with that, just want to say thank you for your time. Great. If you want to come upstairs, it's room 3060 up on the third. So this is in Lauren.
I know,
Yeah.
I think he's out with that.
Yeah. When did you? Older dogs.
Yeah.
Made me think of Edgar with.
Yes.